Hello, this is Usa Michael Park. I'm Chief of Vascular Surgery at the Cleveland Clinic Abu Dhabi in the UAE. We're a main campus of the Cleveland Clinic here in the Middle East. And it's my pleasure to speak to you about carotid endarterectomy. I have nothing to disclose. When I was asked to do this talk, I gave some thought to what the goals of carotid revascularization are. I reached back to the origins of carotid endarterectomy when I mentioned stroke reversal. But primarily, the first goal of carotid revascularization is stroke risk reduction, even in the face of someone who's had a stroke. It's not necessarily to reverse that stroke, but to reduce that patient's profile. The third goal is to minimize procedural complications, and that's something that every operator in this field should be doing is constantly keeping tabs on themselves and keeping track of the results and to figure out ways and methods to minimize their procedural complications. Stroke reversal, it was actually the first goal of carotid endarterectomy when it was invented back in the 50s. There was some controversy as to who did the first one. Dr. Eastcott published on the first one, but Dr. DeBakey post facto published a report in the 70s about a carotid endarterectomy that he did in the 1950s. When asked why he took so long to publish the case report, he said he'd like to get long-term results before presenting his data. That said, this indication is actually kind of an archaic one, although it is the unicorn. I like to call this the unicorn of carotid indications. This CT scan I have projected is of a case I had when I was a bit younger. The patient was admitted with a stroke after bowel surgery, and this was before formal stroke programs, but at the very beginning of the NIH recommendations for rapid evaluation and consideration for thrombolysis. This is in the late 2000s, and this patient clearly was not fit for thrombolysis and had a left hemispheric stroke, which left her aphasic for a while, for about a 4-hour period, and then got better. When she got better, the plan was to electively operate on her carotid lesion. What happened then was she had the CT scan and showed that, in fact, it was a string sign, and there was some debate as to whether or not we should operate as she had gotten better spontaneously, and the other 3 cerebral vascular vessels were widely patent. As I was examining her, she became densely aphasic and hemiplegic, and the stroke neurologist was right in front of me, and she was in the ICU, and we were able to call over the anesthesiologist and pretty rapidly make the decision to take her to the operating room for an emergent carotid endarterectomy. This was made. The discussion primarily was to try to reverse this because the patient faced a grim future if she was so densely hemiplegic and aphasic. And surprisingly enough, despite the high risks of this operation, we were able to get the plaque out and reflow her, and she woke up being able to speak again and was no longer paralyzed in half of her body. This kind of indication rarely happens. Nobody really has a stroke right in front of you, but it is something to think about, and that's why I call this the unicorn. The broader need was and still is in stroke prevention in those who've had strokes and those who are at high risk for strokes. Modern day management of acute stroke is with early intervention, and the rule is for those with NIH stroke scale greater than 6, to get a stat non-contrast CT to rule out hemorrhage, and if they are within a time frame of 4.5 hours, to undergo a thrombolysis, and that's systemic thrombolysis. And the endovascular therapy is also recommended, and that's within a 6-hour time frame for clot retrieval and intervention. Stroke prevention. Why the need for stroke prevention? Well, stroke is the third leading cause of death, and it causes its incidence is high in the same scale as a heart attack and the major cancers like lung cancer, colon cancer, breast cancer. Disability is very high. It causes a permanent disability in 71% of patients at 6 months after their stroke, and death occurs in 38% of individuals initially. I believe it's a little bit lower. This slide's a little bit older, and there's a 10% subsequent stroke within the early period. There's also a syndrome of concomitant MI. About 18% of patients have concomitant myocardial infarction, and it's a well-described syndrome of stroke MI that occurs. And so these patients with strokes are monitored for myocardial infarction as well, particularly if they have multiple risk factors. The 5-year recurrent stroke rate, and we'll touch on this later with the trial data, is 42%, and it's about 9% a year. And the post-stroke late mortality is high. It's about 10% a year, and 23% of which is from recurrent stroke. In terms of the patient history, age and sex are important. It tends towards the male sex and older age. But the risk factors are shared with cardiovascular disease in general: smoking, hypertension, hypercholesterolemia, diabetes, and coronary artery disease. This is one manifestation of systemic atherosclerosis that we see, the others being coronary artery disease and peripheral vascular disease in the other organs and extremities. The TIA is a stroke that recovers within 24 hours, and TIAs may or may not show up on diffusion-weighted scans of the brain. A stroke in evolution is something that occurs and then and changes in depth past 24 hours, and stroke is a permanent deficit. The gathering of previous surgical history and history of radiotherapy to the neck is also important if carotid endarterectomy is being considered. On physical examination, I first start with going over the patient's body habitus and skin examination, looking at the likely areas of incision. Again, those who've had previous radiation therapy will have very tough fibrotic skin, and I also look for scars from previous operations, which will make carotid endarterectomy more difficult and carotid stenting more appealing. Cervical mobility is very important. Oftentimes these lesions, although they may appear clear of the mandible, will in fact be very difficult to get to if the patient is unable to extend their neck and turn their head. Again, previous facial and neck operations injuries are also important to observe. A thorough cranial nerve examination is important because these are the nerves that you want to understand at baseline, as well as a thorough neurologic examination. The vascular examination involves listening for bruits and checking for vascular access locations. And then cardiac examination is important, in particular listening for valve murmurs and arrhythmias, which usually will trigger either an echocardiogram or stress test and or a cardiology evaluation. The panel of diagnostic studies available for us to evaluate extracranial carotid disease are pretty much available at most hospitals, and it starts with a good duplex ultrasound. And many hospitals will offer it in the Department of Radiology. I believe that it's really important to have specialty techs that focus on vascular ultrasound and testing, and that involves accreditation. Ultrasound has been proved to be cost-effective and very reliable in terms of being able to repeat across different operators and across different labs their findings. It's relatively low risk. The insufflation, the application of the ultrasound probe doesn't involve moving the plaque or jamming the plaque. It does involve having the patient extend their neck, turn their heads, and various maneuvers. But again, the overall risk of the ultrasound study is very low. The lab criteria vary even in the United States and particularly across the world. Mike's having moved out here to our Abu Dhabi campus, and working with caregivers from 67 different countries makes me realize that how different these lab criteria can be. The simplest one to use is the Society for Radiology consensus criteria, the SRUS consensus criteria, which groups these lesions to less than 49%, 50 to 69%, and 70 to 99%, giving you a clear delineation of mild, moderate, and severe diseases. There's the addition of near occlusive or greater than 99%, but not occluded, and then occluded, and then at the bottom end of the scale is normal. The other criteria is the University of Washington criteria, which breaks it down to finer ranges, and in Europe there's various different criteria. There's the St. Mary's criteria. Again, these ranges are dependent on the findings of peak systolic velocity and diastolic velocity and the ratios of these velocities. Nevertheless, they're all pretty good at screening for lesions that are plus or minus, meaning a Boolean of being present or not. So is there atherosclerotic disease or not? Then that's a very easy one to answer. And then to answer whether it's severe or not is also a very straightforward one, although the different criteria vary in their ability to differentiate between greater than 70% and greater than 80% lesions. The contrast arteriogram is the gold standard for tests. And this was the original test upon which all carotid operations were based on. The percent stenosis is measured in kind of a funny way. I'm going to move my cursor over here. The percent stenosis based on the NACID study, which I'll touch on a little bit later, is done by measuring the distance here, the luminal diameter here, and then minus compared to the luminal diameter at the first parallel segment of carotid artery seen on the arteriogram. So this segment minus this divided by this segment, and it's not like you would think being this compared to some outer measurements, because this is an arteriographic criteria. This, I think, in some ways may underestimate a hemodynamically significant lesion, and therefore I tend to rely a great deal on our carotid ultrasound. But that said, this is pegged as the gold standard, and most accredited labs will screen their numbers and compare their studies versus this gold standard. The alternate gold standard is the CT angiogram, the computed tomographic angiogram. This kind of study only became available after the advent of multi-detector CT scanners about 10, 15 years ago, starting with the 32 slice and then 64 slice scanners. This allows for rapid acquisition of these images timed to the phasing of a contrast. So the contrast is injected into a vein and then allowed to mix and traverse the body. And after a certain time delay, when the contrast is in the arterial tree, the images are acquired. And so it's possible to get excellent angiographic images. That these are 3D reconstructions of these images, which are basically stacked two-dimensional images in the XY plane. This is taken as the gold standard, although I have to say that there is some liabilities to using the CT angiogram as the gold standard, in that the calcium can bloom, and this blooming artifact can overestimate degrees of stenoses. It can be corrected for. But the question is to which degree do you do this? And then NASA criteria can be measured, although again it takes a little bit of consistency in that you measure the narrowest luminal diameter, and then and using the same orientation, you measure the artery at a parallel point, much the same way. You can see this in the same patient. The CT angiogram actually matches up very nicely with the contrast angiogram. The big difference is that you get much more anatomic detail with the CT angiogram, as you can see on the left side. Plus, you get some view to what the plaque is like, and that's actually a hot topic. And that plaque morphology and plaque metabolism may be a better guide to the riskiness of a plaque compared to merely just the degree of stenosis. When we operate on carotid disease, we're really operating to prevent embolization. It's the embolization that causes TIAs and the strokes. Occasionally, you'll have someone with TIAs related to hypotension, let's say due to paroxysmal atrial fibrillation, dropping their blood pressure, and then with a hemodynamically significant lesion, they will experience lateral symptoms. But the majority of patients, we're looking for lesions that are embolizing. And so this kind of dark lesion is potentially soft and full of liquid, although a CT scan doesn't differentiate very well with that. This may also be merely fibrotic. The calcium, fully calcified lesion, that's smooth and focal, and in someone who's very old and it may simply be a lesion that can be observed, but a smooth, dark lesion like this, corroborated by similar images on ultrasound showing a liquid core, may be something that is riskier. The MR angiogram shown here can be done in multiple different processes. This one is done with contrast in someone with Takayasu's disease, but other protocols using activated proton motion called time of flight studies can be used to do non-contrast arteriography. It's a little bit of it takes a little bit of coordination between yourself and the radiologist to properly protocol that kind of study. At one point, the MR angiogram was considered a safe way to study patients with renal disease, but unfortunately, patients with low GFRs are prone to retroperitoneal fibrosis with exposure to gadolinium contrast. The reason why I mentioned the plaque morphology was that there are centers studying the ability to look at plaque in terms of not just degree of stenosis and also shape, but also in terms of metabolism and MR-based micro pathology, basically, and this is with surface coils and various techniques within high field magnets. That's quite exciting, actually, because the question is if you have someone who's symptomatic but has a less than 50% lesion, which doesn't qualify for carotid endarterectomy, but there's proved to have a very metabolically active, inflamed, very nasty-looking plaque. Should you operate on it? And that's an existential question for all of us involved in this field. The endarterectomy is an operation that has gone through more testing than any other operation out there. The patient here is seen with a oblique skin line incision. I choose to do this as opposed to the traditional linear incision that's placed anterior to the sternocleidomastoid muscle. I find it a bit less disfiguring. When the patient has their head down, it basically hides in one of the wrinkle lines. And it's my general principle that the patients are unaware of anything that you did aside from the scar. The operation is done under general anesthesia in my hands. It can also be done under local anesthesia with the patient awake. This is with the artery controlled, dissected, opened, and with a plaque coming out here. It's a rather ugly plaque in a younger patient who smokes. And this is after the repair with a patch on. The carotid endarterectomy can be done in a standard fashion. This is called a so-called standard fashion with a linear arteriotomy. The plaque is removed, and then a patch is sewn on to avoid narrowing of this channel right here. But if you don't have the patch, there is the chance that you could take longer bites and result in a narrowing of this segment of artery. But really, it's actually the after effects and the biological effects of operation and endarterectomy that the patch addresses. The eversion endarterectomy is another form of endarterectomy that I find very useful, in particular with those with short lesions that are at the origin, and also people with long elongated carotid arteries that are redundant and coiled or quite tortuous. You can shorten the artery when you do an eversion. The carotid artery is transected at its origin, and the plaque is removed via eversion. The consequence of this particular approach is that the Herring's nerve, which is the nerve to the carotid baroreceptor, usually gets damaged or cut, and there is a slightly higher instance of hypertension after surgery because of that, I believe. Once the plaque is out and a good endpoint is achieved, the artery is sewn back on to its origin, and this allows you to avoid having a patch material. Just going back to the patch, the most prevalent patch material today is bovine pericardium. Alternate materials include PTFE and Dacron. It's my opinion that those tend to bleed more from needle holes than the biological patch like this. This bleeds less. The other patch of choice of some surgeons is saphenous vein patch, and I generally use that when there's an infection, a wound infection or a patch infection. Shunt use. So a shunt is commonly used to try to reduce the rate of stroke during these procedures. And there are several different strategies. One is selective use of shunts. That's not using a shunt unless certain criteria are met. In those who operate on awake patients with local or regional anesthesia, if the patient develops stroke symptoms with a carotid clamped, a shunt is placed. The other way is is to measure a stump pressure. That's with the external carotid artery and the common carotid artery clamped. A needle is inserted into the carotid bulb, and a pressure is measured from was now a stump from the intracerebral circulation. If the stump pressure is less than 40 millimeters of mercury, that's generally used as a criteria to shunt. That's actually, for me, that's 40 millimeters systolic, but other people use mean pressures. I've seen people use 60 systolic, whether it's pulsatile or not. It varies quite differently. And at the end of the day, it probably doesn't matter. The EEG monitoring is used. In my experience, it was used quite broadly in the New York tri-state area. We had quite the setup with remote monitoring by a neurologist who was across town. Some neurosurgeons also like to use this. I find it relatively cumbersome. I prefer to use stump pressures for selective shunting. There are those who use a non-selective non-selective shunt policy, and starting with those who never shunt. There are those who never shunt, believing in speed and precision, and they're able to achieve low stroke rates. There's also non-selective shunting in those who, in choosing to shunt only those with contralateral disease or with a recent stroke. And then there are the always shunters. I've been partners with several people who always shunted, and they too had good results. There have been multiple publications regarding these disparate and different strategies. They're all able to achieve good results, and by good results, this is a less than 1% to 2% stroke rate, and that is what would be accepted as a good result in most large volume centers. The use of patch has been controversial because there were those who never patched and never everted. The Everest trial was done to sort of to figure this one out, and this was a trial, a randomized prospective trial run out of Italy, where 1,353 patients were assigned to eversion or standard endarterectomy with or without patch closure. That is, about 419 were closed primarily, and 256 were closed with patch. And the outcomes were perioperative and late major stroke, death, and restenosis greater than 50%, and occlusion. If you look at the restenosis rate, this is the meat of this trial. The eversion versus patch doesn't have a statistically significant difference in terms of restenosis rates, but patch and eversion versus primary closure does have a statistically different rate of restenosis. Primary closure is associated with close to 8% restenosis rate. That's restenosis greater than 50%, resulting in both symptoms and reintervention. This drives the recommendation that the patients either undergo a patch closure or eversion endarterectomy. Carotid angioplasty and stenting came to the fore in the late 90s and 2000s, and in fact, at one point when I was in private practice, I was partnered with some cardiologists who were doing this as early as the early 90s, pretty much off-label, with just plain balloon angioplasty. The current modern technique involves low-profile systems and filters, and there's currently the great interest in flow reversal systems, and we'll step through this in just a little in the next few slides. Carotid angioplasty and stenting involves femoral access in the standard CAS procedure, and with selection of the carotid vessels and angiography. Here you can see a left carotid angiogram done with the sheath in the common carotid artery, and you can see the patient has a high-grade stenosis of the internal carotid artery. The next step is the placement of a cerebral protection device. And this is the Achilles heel of the standard carotid angioplasty of stent. This cerebral protection device is basically a net or a trap, some sort of trap that picks up embolism as you intervene on the plaque. The problem is you have to get this wire and device across the lesion, assuming that you're not bothering it, and then deploy it to catch any materials. And that, again, is the Achilles heel. That, and also selecting the carotid artery itself and touching the arch engenders some risk of stroke as well. Once the filter device is in place, angioplasty and stenting is done with stents specifically designed for this location. The stents are typically placed across the origin of the external carotid artery, and multiple studies have shown that this doesn't affect the patency of the external carotid artery. And you can see here, once deployed, the filter device is then retrieved. Often, sometimes the filter device is so full of embolic material that it won't collapse back into its catching sheath and requires some maneuvering to get it out of harm's way. So it seems like this would be the way to go with carotid interventions. And in fact, many patients will come to us seeking a stent without really understanding the data. It's quite appealing because it involves a groin puncture versus an incision in the neck. And it seems to get the same results as the operation, and so we'll go walk through the data. In the 1970s through the 1990s, the carotid endarterectomy was purported to be the most commonly performed operation in America. It was so commonly done by both vascular surgeons and general surgeons that it generated strong opinions about appropriateness, particularly when done in community and local hospital settings with low volumes, where even one stroke or two strokes will result in a high stroke rate. There were editorials in neurology journals and from society presidents in neurology condemning wide application or any application of carotid endarterectomy without adequate data. This triggered randomized control trials, and this is the ACAS trial and the NASA trial in the United States. And this is for very good reason. At that time, community hospital stroke rates of that era ranged anywhere between 6 to 10% for carotid endarterectomy, and that drove this desire to gather data for proper indications and documenting of results. This is a presidential address from Norm Hertzer, our preceding one of our chairman emeritus at the main campus at Cleveland Clinic during a Midwest Vascular presidential address in 1987. Basically, looking back at the Cleveland Clinic data, they were able to show that for symptomatic patients, comparing medically managed groups and surgically managed patients, the strokes were 31% and 7% respectively over a 5-year period. And that was statistically significantly different, and it was quite prescient because this matched up well with the subsequently published NASA study a couple of years later. The carotid endarterectomy trials basically, we're able to demonstrate level 1 evidence showing the efficacy of carotid endarterectomy in the treatment of patients who've had strokes and who are at high risk for stroke in achieving stroke risk reduction. The NACIT trial, published in 1991, was for symptomatic patients, those with 70 to 99% stenosis who've had strokes. The early perioperative results were in favor of medical therapy, in that there was 5.8% stroke death in the endarterectomy group versus the 3.3% stroke death rate in the medical arm. But at 2 years, it was quite clear that there was quite a separation in terms of results. The carotid endarterectomy group had 9% rate of stroke versus 26% at 2 years with the medical group, and 2.5% major ipsilateral stroke versus 13.1% major ipsilateral strokes in the medically managed arm. I would like to comment that the medical management this time involved blood pressure control with what they had at the time, and aspirin at relatively high doses, and all the medications that we have nowadays were not available at that time. The asymptomatic patients were tested under the ACAS trial. And this was those who had 60 to 99% stenoses who were asymptomatic, randomized to medical therapy or carotid endarterectomy. Again, perioperatively, there was a 2.3% stroke rate for the endarterectomy patients, and 0.4% in the medical arm, with arteriography being responsible for 1.2% of the stroke death rate, and that shows you there is some risk to contrast arteriography. Placing a catheter in the aortic arch and within the great vessels in someone with atherosclerosis leads to some risk of embolism and stroke in these patients. The significant finding was that at 5 years, the endarterectomy patients faced a 5% risk of stroke and death versus 11% in the medical arm, and that was able to establish the efficacy of stroke risk reduction, carotid endarterectomy, and stroke risk reduction in patients with asymptomatic disease. The ACST and ECST studies are the equivalent European trials, and they corroborate much of the same results as the American trials. Then, as carotid angioplasty and stenting became available, there was a great deal of excitement as to whether it would supplant carotid endarterectomy. It created a great deal of friction between those who were the interventionalists versus the surgeons. The interventionalists were a varied group, including mostly cardiologists, some radiologists, and some vascular surgeons, and the vascular surgery representing the endarterectomy proponents. That argument, like most arguments, don't work out without data in medicine, and so multiple trials generated data comparing carotid endarterectomy and carotid angioplasty and stenting. This is a laundry list of these trials that were published in the aughts, in the 2000s, and I took the liberty of doing a little spreadsheet to show what happens. Any stroke or death, there tends to be higher rates in the angioplasty and stenting compared to the endarterectomy. Any stroke tends to be higher on this differently scaled view on percentages in the angioplasty and stenting group compared to the carotid endarterectomy in this sort of jumble of all the trials. And it would lead one to conclude that the stroke death rate might be equal. Well, the death rate may be equal between the two. The stroke rate may be higher. The Sapphire trial was the one that is back in the day was the most pointed to by cardiologists as it was most favorable to angioplasty and stenting. It was randomized. It was carotid endarterectomy versus angioplasty and stenting, and had the composite endpoints of stroke, death, and MI. Again, composite endpointing allowed for a smaller enrollment number, but caused some controversy. This was what was called a non-inferiority design, meaning it was to prove non-inferiority of the angioplasty and stenting, not necessarily superiority of one over the other. The 30-day stroke rate between the two were equal. The MIs were higher in the endarterectomies, and the stroke death MI were therefore higher in the carotid endarterectomy, and lower in the angioplasty and stenting, favoring angioplasty and stenting. The CRUST trial was done with a lead-in there was a lead-in section of interventionalists to show that they had low stroke rates, and the operators were audited for low stroke rates and high volume. I participated in this when I was in private practice in Iowa, and I was one of the operators, while my partners in cardiology were placing carotid stents in conjunction with the neurologists that were involved in this trial. The patients were randomized to carotid endarterectomy versus stenting, were symptomatic versus asymptomatic. There's a composite outcome of stroke, MI, and death, and the conclusion was there was no difference in composite endpoints. When you broke it down, though, there were differences in the individual endpoints. Peri-procedural stroke rates were significantly lower in the carotid endarterectomy. The peri-procedural MI rates were higher in the endarterectomy, but it turns out most of these MIs were non-Q-wave MIs. They were non-transmural MIs, probably resulting from strain and sympathetic response after an operation. Peri-procedural death were equivalent, and this was actually recapitulated in several different trials as well. The meta-analysis of all randomized controlled trials was done and published in Circulation, the meta-analysis publication of Circulation, and basically it concluded that endarterectomy remains the gold standard for the particular reason that carotid angioplasty and stenting had a higher risk of stroke and composite adverse outcomes, both short and long term. Carotid angioplasty and stenting is associated with a lower cranial nerve injury and MI rate mostly being non-Q-wave MIs. And the general recommendation is for patients without an anatomical reason or a risk-based reason, they should undergo carotid endarterectomy. And that seems to have settled the discussion. But I brought up the point of medical management earlier, in medical management has greatly changed over the 20 years since NACID and ACAS came out. And so if we have beta blockers, ACE inhibitors, aspirin, Plavix, and statins available, how does that work? Well, current medical management involves an ACE inhibitor, aspirin, or Plavix. Dual antiplatelet therapy is not indicated unless there's a specific reason. For example, in the setting of someone who's high risk with carotid or coronary stents, and then statins, smoking cessation, exercise, and weight loss. Those apply to coronary artery disease and peripheral vascular disease, and also here in carotid disease. This has been shown in non-randomized retrospective fashion to be associated with a potentially lower stroke rate than what was seen in the ACAS trial medical management arm, and also NACIT. And so new trials have been formed to evaluate this with a medical management arm. The CREST-2 and ACST are currently enrolling, and will end enrollment next year for CREST-2 and ACST in 2021. And of course, this will continue to refine our approach to carotid disease. I'm going to switch gears a little bit. So now that carotid endarterectomy is the standard and you perform a carotid endarterectomy, the typical board type questions, CSAP, BSAP questions involve these complications of carotid surgery. After carotid surgery, patients may experience stroke, cranial nerve injury, myocardial infarction, hematoma bleeding, hyperperfusion syndrome, hypertension, and hypotension. I'll speak to MIs and hypertension, hypotension, and hematoma briefly because I won't focus on them later. Most patients undergo screening for coronary artery disease prior to general anesthesia and carotid endarterectomy. But that said, some still do escape, and therefore they should be monitored, but not specifically tested unless they have symptoms or EKG changes for MI. The vulnerable point being 2 to 3 days out after surgery and during surgery. The bleeding hematoma is something that bedevils this operation, particularly if the patients are on Plavix and other anticoagulants. In general, I will stop the anticoagulants and Plavix if I can. I keep people on the aspirin. I've largely stopped using drains because we've had data from our main campus that was presented by Chris Smolak showing that drains are ineffective at preventing hematoma and bleeding complications. They in fact don't help, in my opinion. So I've stopped, and to make sure that the patient's reasonably dry before closing the wound is the best approach. Hypertension and hypotension is something that occurs because you are operating on the carotid baroreceptor. And vagal signals, parasympathetic signals triggered by stimulation of particularly Heyring's nerve at the carotid bifurcation can cause hypotension and bradycardia. That can be associated with increased rates of stroke, and also hypertension. It can result, which may drive a hyperperfusion syndrome as well. These does trigger ICU monitoring in some hospitals and some groups, and some care pathways involve monitoring these patients for 4 to 6 hours after surgery to ensure that they don't have hypertension or hypotension requiring parenteral pharmacotherapy before moving to the floor versus directly just having the patients stay 24 hours in the ICU. The stroke post-op is a devastating complication. As the patients wake up, it's very important to make sure that they move all 4 extremities, follow commands, are able to speak. If they are unable to do so adequately and have lateralizing symptoms, it's the key points are to understand that it's usually a technical error at the endarterectomy that's the cause of this, and so it behooves you to get either a carotid ultrasound or a CT angiogram, both of which can be obtained relatively rapidly. The carotid ultrasound may be hampered by either the presence of a drain or hematoma. The postoperative wound is hard to insonate through. The patient it may be quite painful to do so. but it is possible to get a reasonable picture of flow most of the time. The better study is the CT angiogram, but it does involve contrast. It'll give you a picture of what's going on at your operative site and in the brain. The third option is contrast angiography, and if it proves that if you're able to show that your operative site is clear of disease, and there's suggestion of intracranial embolization, the only way to rescue yourself out of this is with a neurointerventionalist performing angiography and intervention with embolism retrieval, and embolism retrieval in the lab. So again, it's most of these are the result of technical errors or problems at your operative point. Your patch may be causing a stenosis. There may be a dissection. There may be a clot formation at the endarterectomized area due to low flow. So it's first and foremost very important to evaluate this. Ideally, you're going to be evaluating this before you leave the operating room. Have the patient wake up, move everything. If they don't, then you can rapidly reopen the wound. Get the patient under general anesthesia again, reopen the wound, and check your patch and check your artery right there on the spot. The funny thing is, strokes require fairly specific areas of the brain to be hit, to be manifest on the physical examination. Oftentimes, you may have a normal physical examination and therefore think you're clear of stroke. But in fact, when you look at everybody with a carotid intervention, whether it's operation or stenting with diffusion weighted MRI, it turns out that there's strokes associated with both carotid endarterectomy and angioplasty and stenting. There appears to be in these smaller studies of several hundred people at most, double the rate of stroke with standard angioplasty and stenting compared to endarterectomy, and I believe it has everything to do with passing sheaths, wires, and catheters and embolic protection devices through atherosclerotic plaque materials in the arch and carotid artery. You can see here in this study that there was a 41% detection of strokes in the carotid angioplasty and stent group. Again, most of these are not manifest on the physical exam as actual strokes, and these silent strokes, the question is what happens with this? Well, there is the entity of multi-infarct dementia. While you don't have the physical manifestations of a stroke right away, it does affect. It may affect your cognition and neurologic health later on. And why does that work that way? Well, there's this game out in Japan and Korea called pachinko, and basically you hurl balls up and they fall down, and when they fall into a certain hole, you get bonus points. Well, let's say this bottom middle hole is the stroke hole, and so any of these holes may be stroke holes, but in fact the one that shows up on the motor strip is here. And so in fact, if you sling particles into the carotid, most of them won't end up affecting the motor strip. In fact, they'll affect white matter or just pass through and onwards because they're small, and so you won't be able to detect them. It's a random thing. So even if you have a 1% stroke rate, you're probably having a higher stroke rate based on diffusion weighted MRI if you were checking every patient with a diffusion weighted MRI. And again, it points to the critical importance of good technique and some humility, actually, at the end of the day. Cerebral hyperperfusion syndrome it occurs in patients postoperatively after revascularization. The analog is patients who, for example, who have lower extremity revascularization, their feet and legs swell and turn red from all the extra blood that's going through it, and there's edema, and you treat it by elevating the leg and wrapping the leg up with an ACE wrap. Unfortunately, you can't do that with the brain. The brain gets hyperperfused because it had lost autonomic function during the period of time it had no or very poor primary blood flow. It required collateral flow. This will result in hyperperfusion, and it can be seen on CT late as edema and hemorrhage and stroke and death, but early as headache, and so it's important to treat these focal severe headaches that may occur in patients postoperatively very seriously. I get non-contrast CT scans very early and stat if they develop headaches. And will, if they have hypertension, they need to go to the ICU for management until they're out of it. It used to be believed that patients with high blood pressure to begin with were at risk for this. People also who had very high-grade stenoses were believed to be prone to this. But this interesting paper from Enrico Asher's group with one of my former co-residents, Rich Schutzer and Anil Hingorani, showed that in their large cohort of patients over a 2-year period, they had 9 patients with hyperperfusion syndrome. And of them, 5 patients had undergone contralateral carotid endarterectomy within 3 months. That's a very interesting finding in that going back in my memory, there have been several people who've had bilateral disease and who have developed hyperperfusion syndrome. In the worst cases, it can be quite bad, but thankfully no one has died or had strokes. But what they found was that the patients with hyperperfusion syndrome did indeed have higher ICA volume flow. This is an ultrasonographic calculation, much in the way of fistula flow is done, and the peak systolic flows are also higher in these patients. The degree of stenosis was not found to be different, but again, these are small numbers, and the history of hypertension prior to this was not different in these two groups. Again, very low numbers, but the contralateral CEA finding was an interesting risk factor. Cranial nerve injuries are a popular topic on the CSAP and VSAP and on the spring examinations for general surgery and vascular. The cranial nerve injuries that can result from carotid endarterectomy include injuries to the marginal mandibular branch of 7, the glossopharyngeal nerve 9, and recurrent laryngeal nerve of 10, the vagus nerve, and 12, the hypoglossal nerve, the most commonly injured cranial nerve. The marginal mandibular branch injuries will result in asymmetry of the face. On the side that was injured, patients are unable to raise and smile on that side well. It can be quite bothersome for many patients having this asymmetry. Typically passes. It's a compression injury of the nerve rather than an actual transection. Although whenever you use cautery, unipolar cautery underneath the platysma, I really feel that the current will pass through paths of least resistance, and these involve the nerves. And I believe that there is potential for direct electrical nerve injury, which I believe generally tends to be permanent. The crush injuries generally resolve. Patients will have complete return of function over several months. But it's important to reassure these patients that we have to wait it out. The glossopharyngeal nerve injuries are quite devastating. This is typically a complication of high carotid lesions where you do maneuvers to try to expose high carotid lesions. So in the days when we did high carotid lesions, we would operate. We have various different techniques to get to them, including subluxation of the jaw, having nasotracheal intubation, having the oral surgeons wire the teeth to move the jaw over to one side, dividing the posterior belly of the digastric, cutting the styloid process, and dissecting quite high. Those put you, particularly going very high, puts you at risk for injuring the glossopharyngeal nerve. And the complication is devastating in that you lose innervation to the palate and pharynx, if the patient had a left injury, you'll see this when you look at their uvula and have them go, the right side raises appropriately, but the left side does not. What typically results is aspiration of food and fluid liquids. It's devastating because the patients are unable to take orals and have to have nasogastric or enteral feeds through a peg until this recovers. It may be a temporary situation if nothing was directly cut or burned, but again, it's quite unnerving to have to wait several months even for recovery to occur. If it's a permanent injury, the patients will need permanent enteral nutrition because they will be aspirating. Again, this is an injury best avoided, and in the modern setting, getting a CT angiogram or performing the ultrasound yourself lets you see exactly where the carotid bifurcation is and whether or not a carotid lesion is surgically accessible. If the lesion is high, above C1, C2, if the endpoint goes that high, the better option would be the carotid angioplasty and stent to avoid these kind of injuries from going so high in the neck. Vagus nerve injuries cause paralysis of the vocal cord. Postoperatively, the patients will be quite hoarse when you ask them to speak. They will be unable to speak at a normal volume. They'll only be able to speak like this because their vocal cords do not come together. It sounds like they're doing a loud whisper, or they may sound quite raspy. I think I've seen this injury show up late when I believe the endotracheal tube caused some swelling of the cord, allowing for phonation to occur. But then once the swelling disappeared, the vocal cord paralysis was manifest. It can be treated by injection of the paralyzed cord to bring it close to the non-paralyzed one to allow for phonation. It will never be the same voice as before the injury. It can be quite devastating for people who rely on speech for their careers. Typically with time, these injuries can recover, just like as in the other injuries, as long as the nerve was not transected. These occur as a result of clamp, typically, or dissection of the carotid artery. The 10th nerve runs lateral and posterior to the carotid artery, and can be quite intimate with it. To properly clamp the common carotid artery and internal carotid artery, you have to have it dissected well away from this, and sharp dissection under direct vision is the best approach. The spreading technique can result in injury to the nerve. And then application of cautery anywhere in this area can be disastrous. And therefore, I strongly recommend using either bipolar cautery or any of the energy devices like ligature or sonic incision, ultrasonic dissectors that are sized for hand dissection. I found very handy in dissecting this part of the body. And the 12th nerve is the one that most commonly occurs again with any kind of exposure of the distal internal carotid artery. This runs typically under the posterior belly of the digastric muscle, although its location can be quite variable. In some patients, I found it to be actually slung quite low, and it's easy to mistake it for part of the ansa cervicalis nerve complex. When you see it, you have to make sure it is or isn't the 12th nerve. I typically don't go chasing after the 12th nerve to identify it if the dissection is sufficient to do the endarterectomy without going that high. Then I don't necessarily go looking for 12. I think manipulating and touching it can cause it to not work so well either. When you have to mobilize it, you have to take down arteries that sling across it, typically a branch of the external carotid artery, and multiple veins sling across it, tethering it back. That can cause troublesome bleeding. Again, random applications of clips and cautery can permanently damage this nerve, and so therefore those kind of maneuvers are best avoided. When it's injured, the patient will have the tongue protrude towards the side of the injury, and so a midbrain stroke will cause paralysis in the direction away from the carotid artery, and so people sometimes mistake this for signs of a stroke. In fact, it's signs of a 12th nerve injury. And so if the patient's had a left carotid endarterectomy and their tongue deviates to the left side, they've had a 12th nerve injury. Again, if the nerve was not specifically burned, cut, clipped, clamped, it should recover with time. Typically, what happens is once the 12th nerve is mobilized, it is retracted to allow for greater visualization of the distal internal carotid artery, and that typically results in the crush injury. So we're switching gears again. There are people, so we operate, going to step back and review, we operate on patients who have had strokes with greater than 50% stenoses, or patients who've had who have no symptoms and greater than 60%, although we generally now I generally operate on patients over 70 or 80%, and there's specific reasons for that. When you have a 60% lesion, you have to operate on around 10 people to achieve a benefit for one of those patients, whereas with a greater than 80% lesion, that number drops to around 4. 4 patients needed to treat to get benefit. And so at main campus, we generally keep to greater than 80%. That's because it's our ultrasound criteria is built around that range. Here, I've gone back to looking at the patients and individualizing treatment. Good risk patients with lesions over 70%, I will offer endarterectomy to. one instance where if you have an occluded internal carotid artery, typically that protects you from embolic strokes, except in this one situation. Occasionally you get someone who will have embolic strokes ipsilateral to an occluded internal carotid artery. After you've carefully assessed to make sure that there isn't a string sign type narrowing of the internal carotid artery, you may find that in fact you have heavily diseased external carotid artery as well, and someone who's had a chronically occluded internal carotid artery. These patients, when you check out their external carotid artery on ultrasound, will have diastolic flow, which is more consistent with internal carotid artery. That's because the collaterals, the transcranial collaterals that occur from the distal branches of the external carotid artery cross the skull into the brain to feed the ipsilateral hemisphere. That's a pathway for embolism, and so in fact, these patients will embolize from the plaque that's at the bifurcation up the external carotid artery. The treatment for this is an external carotid endarterectomy and ligation and division of the internal carotid artery with a patch. It's one of those oddball things that may show up on your exams, and it's good to know. I'm going to change the range just a little bit, speak to non-atherosclerotic carotid disease, in particular Takayasu's, which is a personal favorite of mine, having worked at both clinics, Mayo and now currently Cleveland Clinic. We see referrals of these patients, particularly from our rheumatology partners. Takayasu's disease is an autoimmune disease affecting classically younger to middle-aged women, and it causes occlusions of not just the great vessels, it can also affect the iliacs. Major branches of the aorta can be affected with this vasculitic narrowing. This patient, shown here, has severe narrowings over long segments of the right common carotid, left common carotid, and left subclavian arteries. The only blood flow to the brain is through a right vertebral, but that seems to be sufficient, as this patient was completely asymptomatic despite having active disease. And that's the thing is that you really can't or shouldn't intervene unless there's ongoing symptoms, and you shouldn't intervene in the setting of active disease. These lesions tend to be heavily inflamed, and there's a perivasculitis, and everything tends to be stuck down, and these lesions can't be endarterectomized. They should be bypassed. There's increasing literature, starting with a fairly reasonable series from Dr. Greenberg, from the main campus, looking at intervention, stenting, and stent grafting in particular of these lesions. I'll present you a case that I did. It's a young man with Takayasu's whose other great vessels are occluded, but this one and a vertebral, I think, was patent. This patient's common carotid became aneurysmal once the disease was in remission for several years, and it was lined with this dark material. The patient was asymptomatic, but the aneurysm was growing and growing in a way that made me concerned that at a certain point it would be not easily treatable with intervention, as it was as the patient had nearly a common trunk with the right brachiocephalic. So the options were to continue to observe this patient whose aneurysm was growing, wait for symptoms, or bypass or intervene. If you look at the artery above it, it's affected by vasculitis all the way up to the bifurcation, and that's a typical pattern for Takayasu's, and so. A extra anatomic bypass from one of the other great vessels was probably not a great idea. Just following this in this young patient with otherwise good risks seemed like an opportunity to miss the window for adequately treating with the available stent grafts, and therefore I offered intervention. The patient, this was a hybrid intervention where I would access the carotid artery above where it was normal through a surgical exposure, and then through that while clamping the outflow arteries for cerebral protection. Intervene, and you can see I had left arm access, and as well as retrograde access to the left carotid, and I placed a stent graft across the aneurysm with pretty good angiographic results covering the aneurysmal segment. This patient did well, and that was during my time in Ohio, right before I left, coming here to Abu Dhabi. And a final note, I guess touch on carotid subclavian bypasses for intervention. So, for revascularization. So, patients with carotid disease will have tandem lesions at the aortic arch or proximal to the carotid bifurcation, as well as downstream disease. In the setting of inflow disease or proximal disease, the criteria for treatment or revascularization is not as well defined. At Mayo under Ken Cherry, we had I was taught that we had pretty good justification if the lesion was over 70% and the patient was as yet asymptomatic. It was important to try to get blood flow into that. I've backed off from that in so much as I intervene on these now and do these bypasses less often. In the setting of patients having intracranial disease in tandem with extracranial carotid bifurcation or internal carotid disease, the dictum is to treat the extracranial disease first if the patients are symptomatic, as that will often clear their symptoms rather than having to do both simultaneously or approach the intracranial disease first. But this is an illustration from Mark Marash's technical paper on carotid subclavian transpositions. It was a very nice illustration of the bypass. I usually all these previous illustrations I've drawn myself. This paper is I think a classic in describing both the bypass but also the transposition in wonderful detail. It's a great paper to have in your armamentarium for upper extremity cerebrovascular reconstructions. I'd like to finish with a plug for vascular surgery. We, as a field, operate in both the open and endovascular realm. I chose this field because it gave me the opportunity to operate all over the body and in all body cavities. This patient presented with a contained rupture of a thoracoabdominal aortic aneurysm. And these patients, the patient was quite stable. These patients represent the highest risk for the old-fashioned all-in-one repair. Those numbers never got better than around 20-30% rate of death or paralysis in type 2 open repairs done all at once. in the modern era, we can now offer hybrid repairs or total endovascular repairs that are typically staged to reduce the risk of paraplegia. In this patient, because they had a previous ascending dissection, they had an ascending graft, and I used this to do a debranching of the great vessels, and then place a stent graft down to the celiac. The stage 2 of this repair is a hybrid revascularization of what is now formerly a type 2 thoracoabdominal aneurysm and is now a type 4 thoracoabdominal aneurysm. Kind of a little bit off topic, but because it did involve cerebral vascular vessels, I did include it in this talk. These are the carotid trial references. In conclusion, carotid endarterectomy is still the gold standard for carotid revascularization. Carotid angioplasty and stenting does have a very important role, in particular in that earlier mentioned indication of stroke reversal. It's part of the armamentarium for the neurointerventionalists for patients with acute stroke, along with thrombolysis and intracranial intervention. And it does have an important role in patients at high risk for open repair. The patients with asymptomatic disease are justifiably treated over 60% based on the ACAS trial results. The patients who have 50% or greater lesions who have had strokes or TIAs are justified for repair based on the NASCET study. The critical point of the current development and principles of carotid surgery are that it's important to keep track of your results in the form of a personal registry and also a departmental or hospital registry or institutional registry to keep track of your outcomes. It's a laudable effort, but it has a very important point in that all things are local, and you have to be able to fix problems in an open, transparent manner if complications do occur, and to improve the system. It's not just one person usually, but also decisions made and systems around the care of the patient that results in success or complications. Thank you very much for the opportunity to give this talk, and good day.